Hello, I am very excited to present on PrEP use during pregnancy and breastfeeding. It is an honor to speak with you today at this workshop, for which I am very grateful. Although I've worked on HIV in communities other than my own for some time, primarily in Kenya, I fully recognize that my perspective is that of an outsider academic. I also recognize how my positionality and privileges influence my perspectives. I will be using binary gender terms when discussing pregnant people because our team's studies are among pregnant people who identify as cisgender women, but I acknowledge that pregnancy is not only experienced by those who identify as cis women. My talk will focus on answering two key questions. The first is, what do we know about PrEP and pregnancy to date based on available data? And the second is, what don't we know? And I'll highlight the scientific gaps along the way. HIV incidence is alarmingly high among young women in some settings and persists during periods of pregnancy. A recent study by Dr. Carrie Thompson, using data from women, primarily in Kenya and Uganda, found that the per-coital act risk of acquiring HIV was twofold higher during pregnancy compared to non-pregnant periods, which underscores the high risk for HIV observed among pregnant women in some settings. When mothers become acutely infected with HIV, viral loads can be high, which increases the likelihood of vertical transmission. Approximately 1/3 of all vertical transmissions of HIV are attributed to acute maternal HIV infection. Therefore, preventing HIV during pregnancy has dual benefits for women and infants. In 2017, the World Health Organization released recommendations that include HIV-negative pregnant women in settings where HIV prevalence is high among the groups who should be offered PrEP. Several HIV high-burden countries are considering or are launching programmatic PrEP delivery for pregnant women, including where much of my team's work is conducted in Kenya, which explicitly includes pregnant women in its national PrEP guidelines. WHO's recommendation was due in part to the data from women living with HIV who had taken TDF-containing antiretroviral therapy during pregnancy, which built a strong safety profile for prenatal TDF use. TDF, or tenofovir disoproxil fumarate, is the drug in both PrEP and ART that there were some safety concerns about. A systematic review, which included 33 studies, concluded that given the available data, there was no safety-related rationale for prohibiting PrEP use during pregnancy. Very few of the included studies, only 2 in fact, were specifically on PrEP. Some differences between exposure groups were observed, specifically bone mineral density differences among TDF-exposed infants, though clinical significance of these findings are unclear. Since then, a few more PrEP-specific analyses have been completed. 3 of the 5 analyses existing to date used data from the initial PrEP clinical trials and found no difference in pregnancy and infant outcomes between PrEP-exposed and unexposed pregnancies. But it's important to note that pregnancy was an exclusion criteria for all of the initial PrEP RCTs, and study drug was stopped at pregnancy detection. In some of these studies, women were required to be on a hormonal contraceptive method as well. So these studies really only provide data on time-limited, very early first trimester exposure among women who became pregnant while enrolled in clinical trials, which may not be representative of pregnant women at large in these settings. An analysis led by Dr. Renee Heffron and the Partners Demonstration Project evaluated outcomes among 30 women who became pregnant and elected to continue PrEP during pregnancy. So they had longer prenatal PrEP exposure than the RCTs. And these 30 pregnancies were compared with outcomes from 96 pregnancies that occurred in the placebo arm of the initial Partners PrEP RCT. And there are no differences observed in adverse pregnancy and infant outcomes at 1 year, though the sample size is very small. An analysis led by Julia Dettinger from our team's PRIYA program, which I'll talk more about in a minute, abstracted birth records for mothers attending infant immunization visits at 6 weeks postpartum in Kenya. Mothers were attending clinics where PrEP is being offered programmatically during routine antenatal care, and women were asked retrospectively whether or not they had used PrEP during pregnancy. There are no differences in birth outcomes observed between PrEP exposure groups, but it's important to note that these were all women with live infants at 6 weeks postpartum, so there is a selection bias, and this analysis relied on self-reported PrEP use only. An article by my friend and colleague, Dr. Kenneth Mugwanya, also from the Partners PrEP study team, quantified maternal tenofovir levels in plasma and breast milk following directly observed PrEP ingestion. Plasma samples were also tested on infants, and the team found very minimal tenofovir in breast milk and even less among infant samples. However, in utero PrEP exposure from mothers to infants has not been previously evaluated, and we'd expect much higher infant exposure levels in utero than via breast milk based on known pharmacokinetics of tenofovir. And it is also the in utero exposure that may have implications on bone development, which was seen as an effect of prenatal exposure to TDF as part of ART. These results on in utero tenofovir transfer will be presented at this workshop later as an oral presentation, but very briefly, we collected hair samples at birth from women living with HIV in the FACTS cohort who had reported the use of TDF-based ART regimens at some point during pregnancy and their infants. Tenofovir hair concentrations were analyzed at the UCSF Hair Analytical Laboratory, and we found that 80% of infants had tenofovir hair levels above the upper limit of quantification at birth. And you can see them clumped at the top here. The infant tenofovir hair levels are on the y-axis and the mothers are on the x-axis. And there is a weak yet statistically significant correlation between the two. I want to draw your attention to the last row outlined in red here, which are the infant to mother ratios of hair tenofovir concentrations in this study. And the mean log ratio was 1.08 and the median was 1.21. And this confirms what we hypothesized and what I mentioned before, that in utero tenofovir exposure appears to be very high. Prior studies have assessed in utero tenofovir exposure via short-term metrics in plasma, cord blood, amniotic fluid, and meconium, with an estimated infant to mother tenofovir ratios of between 0.6 and 0.9, with our study confirming that such transfer appears to be cumulative. Our study team also has a new study which will evaluate infant PrEP exposure during pregnancy and breastfeeding in Kenya. Aim 1 of that study will use the same approach of analyzing tenofovir concentrations in paired mother-infant hair samples collected as close to birth as possible to quantify in utero PrEP exposure. We will also follow mother-infant pairs through 5 years of life to evaluate longer-term infant outcomes following PrEP exposure in utero and via breast milk, including bone development and neurocognitive outcomes. Here is a photo of our study staff, Joanna and Pauline, practicing hair collection, and this is what our hair samples look like, so please stay tuned for future results. So to summarize this section, there are a few PrEP-specific safety studies. Fewer studies quantify infant PrEP exposure, and no studies have quantified in utero PrEP exposure, which may be more important for bone formation. And prenatal PrEP safety analyses have not quantified maternal PrEP adherence to date, which is also an important part for accurate exposure measurement. And our team hopes to fill some of these gaps with our ongoing work. The lack of safety data in pregnancy is not unique to PrEP. Pregnant women are often systematically excluded from research studies, but this leaves us with very limited data on effectiveness and safety of drugs for pregnant women. And there's a move now more towards informed inclusion rather than compulsory exclusion, but still very few drug studies include pregnant women. And there are two powerful statistics to bring this point home. 95% of phase 4 drug studies exclude pregnant women, yet 78% of women are exposed to a drug during pregnancy that has no adequate and well-controlled studies among pregnant women, or animal studies have indicated potential harm. So it's not that women are not taking drugs during pregnancy, it's just that pregnant women are unfortunately excluded from most drug studies. I'm going to switch gears now and move to our team's suite of projects aiming to address implementation science gaps for delivering PrEP to pregnant women in Kenya. In the first project, we aim to answer, if offered, will pregnant women even want to go on PrEP? The PrEP implementation for young women and adolescents, or PrIYA program, provided real-world evidence on delivering PrEP to young women integrated within 16 routine maternal child health clinics in Kisumu, Kenya. PrIYA's approach was to integrate HIV behavioral risk assessment and PrEP services directly into routine antenatal and postnatal care. And this means that women were counseled on PrEP, and if they would like to initiate, they received PrEP pills directly from the clinic where they received their antenatal and postnatal care, often from the same nurse. And here are nurses Christine, Joyce, Veronica on the left, and Rose on the right. And they're all PrIYA nurses who provided routine maternal child services while also counseling and initiating pregnant and postpartum women on PrEP. PrIYA was also engaged in raising awareness about PrEP in the community. Here are PrIYA nurses Tony, Pauline, Emma Joy, and Yvonne carrying a banner through Kisumu saying, "Ask me about PrEP" during a World AIDS Day event. And PrIYA nurses served in a role as community PrEP ambassadors. PrIYA also had a facility mentorship program where healthcare workers were taught about PrEP and why it's important to offer PrEP to pregnant clients. And here's our project director, Felix, presenting a slideshow for healthcare workers. And these were well-attended sessions and often the first forum for healthcare workers to raise concerns about incorporating PrEP into their clinical practice. At the end of December 2018, PrIYA had conducted over 26,000 PrEP screenings within routine care settings, and over 4,600 young women initiated PrEP within the PrIYA program. About 22% of women who were offered PrEP initiated, and if we look at PrEP uptake among women with specific risk factors, uptake is much higher. Nearly 80% of women who had a partner known to be living with HIV initiated PrEP, and this supports that pregnant women in settings with high HIV burden want PrEP and will initiate it when offered within routine antenatal care settings. We also learned about why pregnant and breastfeeding women declined PrEP. Among women who did not know their partner's HIV status and declined PrEP, about 1 in 5 reported a low HIV risk perception as a reason for declining. Pill burden was also reported as a reason. Among women who accepted PrEP, less than half continued PrEP at 1 month post-initiation, and this is similar to other demonstration projects. And reasons for discontinuation were similar for reasons for declining PrEP regarding low risk perception and pill burden. And side effects was another big reason for discontinuation in this group. And I'll take just a second to let you know about 2 very new projects our team is working on to address these issues. One is a supplement award to test integrating universal gene expert chlamydia and gonorrhea testing within ANC as an implementation strategy to improve PrEP uptake by identifying pregnant women with STIs who may benefit from PrEP. And here is a room in the antenatal care clinic at one of the sites being renovated to accommodate the gene expert machine, so that is a one-stop shop approach in ANC. And we'll also have a very new study that will test a 2-way SMS tool known as MWatch to enhance PrEP continuation and adherence among women who initiate PrEP during ANC. And this will be one of the first intervention studies aiming to promote PrEP adherence among pregnant women. We look forward to getting these studies started soon. But it still leaves the question, should PrEP be blanketly offered to all pregnant women in HIV high burden settings, or would it be most cost effective to only prioritize women with known HIV risk factors? Our team is also currently conducting the PrEP implementation for mothers in antenatal care, or PRIMA study. And PRIMA is a cluster RCT which compares 2 PrEP delivery approaches within 20 routine maternal child health clinics in Western Kenya. One approach universally offers PrEP to pregnant women regardless of self-reported behavioral risk factors, and the other uses a validated HIV risk score specifically developed for pregnant women to prioritize PrEP offer to highest risk women. We enrolled 4,500 women during pregnancy and follow them until 9 months postpartum, regardless of whether or not they initiate PrEP, to compare HIV incidence by arm. We're nearing the completion of PRIMA follow-up with an anticipated end date in early 2021. Finally, we have a project that evaluates PrEP adherence using mixed methods to explore who among those who initiate PrEP will adhere, since PrEP effectiveness hinges on adherence like all medications. In one qualitative component of the project, we sought to understand PrEP continuation among pregnant and breastfeeding women. We sampled over 100 women from maternal child health clinics that did or did not continue PrEP to see how and why PrEP was working for them or not. And here are a few key quotes. The routinizing of pill taking for supplements and routine follow-up visits for ANC, both unique to pregnancy, appear to be key facilitators for PrEP retention and adherence. And the final study that I'll mention is IMPAACT 2009, which Dr. Benchi may mention later. And the first component is a pharmacokinetic study to determine PrEP drug concentrations during pregnancy and postpartum under directly observed conditions to establish quantitative adherence thresholds. And this question is important because there's evidence that tenofovir levels are lower during pregnancy, likely due to normal physiologic processes that occur during pregnancy, like hemodilution. Preliminary results from IMPAACT 2009 were presented at PRIYA this year and found that directly observed setting of near perfect adherence, tenofovir diphosphate concentrations in dried blood spots were about 1/3 lower in pregnancy compared to postpartum. It is unknown whether lower concentrations will affect PrEP efficacy. No studies to date have identified the level associated with HIV protection in cis women, let alone pregnant women, and studies are needed to characterize the PrEP adherence efficacy relationship during pregnancy and postpartum. And this may also make missing pills less forgiving among pregnant women, though more research is needed to understand the clinical implications of these findings. So in summary, PrEP appears safe, but data on longer-term outcomes are still needed. It appears pregnant women accept PrEP when offered within antenatal care, but we also need to understand the dynamics of PrEP use within the context of pregnancy and whether there are interventions possible to support sustained PrEP use among pregnant women who want PrEP and could benefit from it. The impact of newer PrEP agents may be especially important for pregnant women moving forward. For example, the Microbicide Trials Network leads an ongoing study on the dapivirine ring among pregnant women. And the studies that I discussed here are not exhaustive of the work in this space either, and other groups are conducting fantastic ongoing work on PrEP use during pregnancy and breastfeeding that I did not have time to mention. And this photo is of one of our PRIYA nurses, Levine, by the way. And she modeled for our educational materials, which are part of a training module on PrEP for maternal child health nurses, developed as part of the PRIYA program, which are available on PRIYA's website at the link here in case you'd like to explore more. This body represents an immense collaboration between the University of Washington and Kenyatta National Hospital and others. We thank our funders, participants, collaborators, and staff, and a special thanks to my mentors for believing in me and taking a chance on me as a trainee. And now I hope that you please ask lots of questions. Thank you.